So we're going to switch gears quite a bit today from stuff that you guys have talked about yesterday and today, and we are going to discuss implicit bias, microaggressions, and inequity, barriers to a healthy culture. Now, the major thing that I wanted to say about this is that this is a more difficult conversation to have via Zoom. So usually, I've never done this through Zoom. I've always done this as a live sort of interaction. So if there are things that you guys want to say, I do have my chat box open, and I can put this other chat box to this Q&A chat box open as well. So if you do have things that you want to bring up, just go ahead and type them in, and I'll try to address them as we go along. Okay. So what is implicit bias? This is a topic that I think some of you may have more knowledge of than others, but basically it's attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. We all have them. They're pervasive. It doesn't necessarily align ourselves with our declared beliefs, and it generally, but not always, favors our own in-group, so our affinity group, whatever group that we're in currently. And this is the main thing is that this is not something that we should be ashamed of and try to be judgmental about, because all of us have implicit bias. So one example that I like to give is if you think about Cracker Barrel, for example, or Huddle House, and you think about, okay, what type of people go into Huddle House or go into Cracker Barrel to eat, those are all biases that we all have about, preconceived notions of what things might be, and if we see, and so that's an example of a pretty simple implicit bias, so that's an example of that. There are other implicit biases that can be much more detrimental and damaging, and that's what we're going to talk about today. So how does unconscious bias impact workplace decisions? Well, it can impact us in recruitment, i.e. residency interviews, faculty recruitment, staff, how we choose medical students. A lot of things can impact that. Hiring decisions, whether we're going to pick candidate A over candidate B, salary and resource allocation, OR time, for example, OR time. There can be unconscious bias at play with OR allocation and salary support. It's not uncommon for people to say, oh, well, you don't have a family, therefore you may not need as much support as this other person, or vice versa. Although I think it's much more subtle than that. It's not as blatant, but that's the undercurrent that can be guiding some of these decision makings. Performance reviews are prone for unconscious bias because of our preconceived notions of what an individual who looks like this person should act, and I've been told by my superiors and by others who are more senior than me that if they see an Asian female, that there is a bias towards this person being submissive and not and very quiet, and those of you who are here who know me, probably those two adjectives don't come up to the top of the list in describing me, but that's an example of how if you look at someone and those perceptions might impact how you would evaluate that person. Retention and promotion, similar things. Teamwork. So, and we'll talk a little bit about this. Sometimes someone who is very gung-ho and tries to bring everyone together may be considered a very much a cheerleader and very collaborative. However, that similar sort of approach to working with a team, but coming from a different gender, from different race, may be viewed entirely differently. And I think that you guys can probably think of examples like that. And it's not just gender. It can be the biases against gender or the biases against race can also come from that same affinity group. And the clinical environment is also a location where unconscious bias can come into play. There's been several papers written where people who come into the ER with different color skin or different background, or those who don't speak English fluently, will be treated differently than those who aren't. So there is a test that you guys can take. It's through Harvard, and that's the website here at the bottom. There's a bunch of different types of implicit association tests based on religion, disability, sexuality. There's one on gender science, which is very interesting because you can kind of tease out what sort of biases you may have in the workplace or in your day-to-day life. So if you were to Google, and I'm sure some of you have seen this before, if you do a Google search and type in doctor, what sort of images might come up? And as you can see here, many of these images are all pretty similar in appearance. Most of them are males. There's a few females. But basically, this is when we think of a doctor, and there's that famous joke where this kid comes into the ED and says that my doctor, my mom can't operate on me or something like that, and it's really because his mom is a doctor, and the ER doctor didn't recognize that his mom could be a doctor. And this happens to us many times, at least for me too. And I know just within the past 6 months, I was in the anesthesia pre-op holding area waiting to talk to my patient, and I was standing there, and the anesthesiologist, who was a resident, was talking to the patient, and I waited very patiently until he was done speaking to my patient. And then when he was done, he turned around and pointed at me and said, "And here's your nurse to talk to you about the whole process of getting you back into the operating room." So that didn't go over real well. But it was an opportunity for me to educate. All right. Here is some examples that's done quite a bit in the business world in terms of looking at implicit bias and workplace decisions. So we have white names on the left and African American, ethnically diverse names on the right. And it's been shown that the callback gap is about 50% attributed to name categories. So someone who is an Ann or an Allison versus an Aisha or a Keisha will have different types of callbacks just solely based on their names. And one of the things that the orchestra has done, and this is something that's been done worldwide, and I don't know how many of y'all know this, but in an effort to increase the diversity of first violinists and other musicians in the orchestra, the auditions are done blindly. So they're behind a curtain, they're playing their instrument, and the people who are evaluating them are the other side of the curtain, so they can't see anything about the individual. And so they're judging the musician based on their performance that day on that musical piece. And with that, they were able to increase the diversity of of many of the orchestras around the world, which I find fascinating. So letters of recommendations can reflect gender bias. I think that it's very important to try to, and perhaps you guys will not be in the position to write letters at this time, but you might be writing comments for your medical students, or if they, and for other co-residents at times. And I think it's very, very important to try to codify what we're evaluating. And I think that's where it's very important to have strict parameters. So I would recommend that if you are evaluating medical students, to ask, what are the parameters we're supposed to be judging the medical students on? Is it surgical skill? Is it ability to examine a patient and then come back and present to me? What are the things you want me to evaluate the individual on? If it's an open-ended kind of, well, let me know what you think about the candidate, that's when there's a lot more opportunity for gender bias to rear its ugly head. So for male applicants, their letters tend to be longer. They're they're usually more excellent. They have a strong language, such as a brilliant scientist, a trailblazer, one of the best, confident, assertive. And these words are not commonly seen in letters for female candidates. And I've had questions when I give this talk in the past, well, is it because of the author? And not necessarily. Authors who are male and female can both fall into these categories of writing these types of letters. So I think for female applicants, their letters tend to be shorter. They tend to be more descriptive of their nurturing skills or their caring skills rather than some of the other language, such as a brilliant scientist. And the types of different biases I just want to touch on as well. There are some ways that we can, and if we're conscious and cognizant of what is happening, I think that we can try to overcome it. So affinity bias is when we overvalue candidates with whom we share something in common. So I graduated from the University of Texas for undergraduate, so one way I could be, quote unquote, guilty of affinity bias is if I see someone from Texas or from UT Austin, oh wow, they went to UT Austin, that's where I went to college, and automatically you have this bond that you haven't even met the person yet, and you already have this bond, and that can cloud our ability to really look at the individual in a more discreet and non-judgmental way. Conformity bias, this is very, very common, especially in panel interviews. We'll have a group of people who are interviewing someone, and I might think, I have a little concern about all this change from, if they had a job for 2 years and then a job for 6 months and then a job for a year, and I'm a little worried about that, but no one else seems to be worried about it on the rest of the panel, so therefore my concern must not be really that valid, and so then I won't bring it up. And in fact, let's say it plays out and we hire this person and then they're gone after 6 months, and then I'm thinking, well, I did kind of think that at the beginning, but I didn't feel comfortable bringing it up because the rest of the group was just so into this candidate. So I think it's important when you do panel interviews that you try to query each individual, sort of like when the judge queries the jury on an individual basis. Are you saying yes, guilty, or no, guilty? And that way people may be more likely to speak up. Beauty bias, this is common. We know that people who are tall tend to be more likely to be president. All of our presidents have been fairly tall, as an example. People who are good looking tend to have more success. A halo effect is when you have one very good positive attribute about a candidate, and that just becomes generalized to everything else that's great about the candidate, and you become blind to some of the pitfalls or negative attributes about the person, and that can be detrimental as well. Attribution bias is when we make systematic assumptions about reasons for our own or others' behaviors. Such as sometimes we associate our own successes with hard work. Others can associate that with just, privilege. And so that's something that if you see someone and you see how much they've accomplished, then you might think, oh, well, that's white privilege, or that's just because that they have their parents are this way or that way, and in actuality, if you dig a little deeper, they've actually overcome a lot of obstacles. So not automatically thinking, oh, the reason why they got from point A to point B is because of Z. Confirmation bias is very common, and this is what we do when on our social media platforms. So we usually have people who are friends, like in Twitter or things like that, which are their beliefs are aligned with us. So we're not likely to have people in our Twitter feed or in our Instagram feed that think differently than us. And so once we think that, okay, I don't know, we'll give I'm trying not to give a political example. Let's say that we have a negative impression of movies that are made from Disney. And therefore, every time you see a Disney movie that, because it promotes this feeling that women need to be rescued. So every time you see a movie that Disney puts out like that, you're like, see, I told you that's exactly what they're doing. Here's another example of it. Here's another example of how Disney does this. But then if they make a Disney movie that's about glaciers that has nothing to do with men or women, we don't look at that as a way to say, oh, wow, Disney does make other movies that don't promote women as needing to be saved. And so as you can see, that can make us view institutions or individuals or organizations in one light rather than a more nuanced light. This is an example of how unconscious bias can lead to workplace decisions in leadership. So this was a study that was done where volunteers were told about a manager, and this is exactly what it was said, that subordinates or people who report to James were described James as someone who is tough yet outgoing and personable. He is known to reward individual contributions and has worked hard to maximize employees' creativity. The only thing that was changed was that James is now Andrea, and Andrea's subordinates or reports said that she is someone who is tough yet outgoing and personable. She's known to reward individual contributions and has worked hard to maximize employees' creativity. And I think you kind of know where I'm going with this. 75% ranked James more likable than Andrea, and 80% prefer to have James as their own boss. And it doesn't matter whether the people who were ranking were men or women. We all have the similar bias that we don't want to, that we tend to view women as tough and as someone who is negative, whereas a male who is tough is viewed as a positive trait. So microaggressions is the next thing, and this is where implicit bias can lead to microaggressions. And microaggressions are subtle, kind of under the radar, maybe a little bit not as blatant as, coming right up to me and saying, I caused coronavirus since I am Chinese. So it's not in that light, but I'll give you some examples of what this is, and I'm sure some of you have experienced these. So there are brief and commonplace daily verbal, behavioral, environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, negative racial slights and insults. And this has the potential to have harmful and unpleasant psychological impacts on the target person or group. Oftentimes these are repeated over and over and over again. So I tend to give an example of a mosquito. So if you have one mosquito bite, it's a little itchy, it's a little uncomfortable, but it's not that big a deal. But if you have, a lot of mosquito bites, it can really be uncomfortable and can really kind of make you miserable. Or if you use a bee sting or whatever you want to use as an analogy. So just one is not a big deal. But when you have them consistently happening to you over and over again on a daily basis, and multiple times a day, it can really degrade your sense of well-being and sense of belonging. So these are some examples of some microaggressions. So this Dove used to have this product called Nourishing Lotion for Normal to Dark Skin, and so the intonation, whether it was intentional or not, was that dark skin is not normal, and obviously they took this off the market. And then Mr. Clean is really for Mother's Day, because the inclination is that women are supposed to be doing the housework and not men, because you wouldn't give this to a father for Father's Day. And again, this ad didn't quite have a long life. So here are some examples of things that have been said. You know, you're the doctor, you look so young. I've been told that I was too young to be a doctor, then I was too old to be a doctor, and then I was, I had a patient come in and say that, oh, you're Dr. Chen. I was like, yeah, I'm Dr. Chen. And they said, well, you know, I really wanted a Jewish male doctor. I'm not sure why they couldn't figure that out before they came into the office, but that is what they said to me. And clearly I was 0 for 2 on that front. You know, why aren't you married? Some of the women on the call or men on the call who are single may have this, you know, you're a doctor, you're so attractive, you're so, you know, why aren't you married? And that sort of thing can be very annoying. And these, I'm not going to read all of these things, but some of these are, and one of my favorites is one that I've been asked many times is, how did you learn to speak English so well? And, you know, if depending on how I'm feeling that day, sometimes I'll just say, you know, Rosetta Stone is really great. I highly recommend it. But, you know, that's the sort of thing that can be said. And I just want to show a quick video. It's about 2 minutes long, so this will be kind of like a study break for you guys, okay? I don't know if y'all can hear it.
Hi there.
Hi.
Nice day, huh?
Yeah, finally, right?
Where are you from? Your English is perfect.
San Diego. We speak English there.
Oh, I know. Where are you from?
Well, I was born in Orange County, but I never actually lived there.
I mean before that.
Before I was born.
Yeah, like, well, where are your people from?
Well, my great-grandma was from Seoul.
Korean. I knew it. I was like, she's either Japanese or Korean, but I was leaning more towards Korean.
Amazing.
I'm Shastina. There's a really good teriyaki barbecue place near my apartment. So I actually really like kimchi.
Cool. What about you? Where are you from?
San Francisco.
But where are you from?
No, I'm just American.
Really? You're Native American?
No, just regular American. Oh, well, I guess my grandparents are from England.
Oh, well. Hello, Governor! What's all this then? Dropping the bulletin to you. Let's go 14, 14! Double, toil and trouble! On the camp, beware Jack the Ripper! Bloody hell! Pip-pip! Cheerio! I think your people's fish and chips are amazing.
You're weird.
Really? I'm weird? Must be a Korean thing. Okay, let's see if I can get back to my slides. This is really weird doing this without any response from you guys. So back to that, I think that many of us may have had the same similar sort of interactions where you're asked, where are you from? No, where are you really from? And, you know, people ask me, where are you from? And I'll say, came from Texas. And no, where did you come from? And it's not that it's, I think we just have to be sensitive to that question. And what it makes me feel like, and the problem is that it can make people feel like, well, I don't belong here because you're asking me where I'm from over and over and over again. So clearly you think that I'm like a foreign person who doesn't quite belong here, and you're trying to figure out where I fit in. And I think think in order to have a good team dynamics, it's good to incorporate everyone and to welcome everyone into the team. So things that can be considered microaggressions are a micro-insult, micro-assault, micro-invalidation, and this has been studied very well in the business world. However, it can also be seen in the medical arena as well. And I think we need to be considerate of our staff as well, because many times they don't have the empowerment to really speak up against it. So we need to be very careful when we approach people about speaking, and especially if we're rushed and trying to take care of patients. That's when I think that we become more prone to exhibiting unconscious bias. So microaggressions are similar to, and this is the way Dr. Su has described it, is similar to carbon monoxide in that it's invisible but potentially lethal. And I think that while hate crimes receive the most attention, the greatest damage to life experiences of people of color or people of any minority is that of microaggression. And I think that they can be very, very difficult to report and to discuss with your supervisor or with your residency director or with your chair, because many times those people that you're talking about this with are in the majority group, and they're not experiencing it and they may not be aware of it. And so it's a pattern of being overlooked, under-respected or devalued because of one's race or gender or sexual orientation or anything that makes you part of the minority group. So they can be subtle slights and snubs that devalue an employee, and they're very subtle and kind of maybe even a little underhanded, and the person who's doing it may or may not be doing it as an intentional way, but it is perceived as an insult. And all of this can add up to demoralizing an employee. I have another little cartoon, which I didn't include in this talk, but it talks about how if you have one individual and something like this happens, and then he or she like blows up, like not blows up, but really loses it. Everyone else looking at it may be like, wow, but he or she is so sensitive. That was just like one comment. It's not a big deal. But in actuality, over time, that wasn't the one comment. It was multiple comments, and that just happened to be, you just happened to witness the straw that broke her back or broke his back. And so it is something that is the unfortunate thing is that it does happen as a pattern, happening over and over and over again. Constantly being interrupted at meetings. I think that we've been at meetings where you're trying to say something at a meeting or trying to bring up a point, and yet you're just totally shut down by someone who is in the majority group at the meeting, being left out of an important conversation. This has happened to me multiple times where I should be involved in a conversation that has to do with my clinical practice or my life or my salary or whatever, and yet I'm totally left out of it, and I'm just being told that this is the way it's going to be. Expecting women colleagues to perform social roles at work, and what do I mean by this? I mean that women are more likely to be involved with planning events or social engagements or wellness activities or things that have to do with the social framework of the department. Not being introduced to an important visitor, or being introduced as Amy rather than Dr. Chen, whereas all the other podium presentations who might be male are all introduced as Dr. So-and-so. This has actually been studied multiple times in many different areas. They study this in ASCO. So a bunch of the oncology podium presenters were introduced by their first name, and there's a statistically difference between whether you were a woman or a man as to whether you were introduced by your first name. Shortening your name because it's too difficult to say. I think that fortunately we have a lot of different ethnic diversities in medicine, and I know of many of my colleagues who have very, 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 very long names. I work with a medical oncologist named Dr. Awanakoko, it's a very long name, and sometimes people will want to try to abbreviate it, say, oh, that's Dr. O, you want to see Dr. O. But actually, it's more respectful to say his whole name. Not making eye contact with the individual can also be an example of a micro inequity. So, and I use this just for us to pause and think about what sort of microaggressions do you think you encounter on a day-to-day basis. I think that it's commonplace for, and this is probably the one that's talked about most, is women being mistaken for a nurse. It isn't that nurses are somehow a degradation of an individual. It's certainly not that way, but I think what the problem is that we're not seen as accomplished. We haven't met all the goals and achievements of being a physician. We're not recognized for being accomplished as a physician, rather than the set of accomplishments for achieving a nurse is different than what we would achieve for being a physician. And therefore, it's that sort of disparity that makes it a little unfair for women to only be considered that way, or for men on the floor to be considered one way or the other. To say that I haven't seen a doctor this whole week, and actually you've been the one that's been seeing the patient every single day. Where's the doctor? Are you going to be my surgeon? These are all sorts of things that, believe it or not, I still experience on a daily basis. I think the best way, and I'm going to try to talk about some ways to strategize and what all of us can do to help. It's not just their problem, not my problem sort of thing. If you're in the majority group, it's very useful to have you say, okay, actually, Dr. Chen is your surgeon, or Dr. Chen is a physician, or someone on your team who's an intern or a resident who might be overlooked. I think that those are opportunities for you to step up and say something. Now, this was an ad that Missouri sent out earlier this year, just a few months ago, on Diversity Week. And as you can see here, there's a bit of a problem because all of the individuals who are white have these great aspirations of what they're going to be, a future doctor, a future corporate financier, whereas the African-American athletes are just going to be a woman and a brother. And this created a lot of headache for Missouri, and they took down this ad very quickly, but not until everyone had captured it and sent it around and everything like that. So this just shows how even with a big organization and a big group that is really striding to it's NCAA Inclusion Week, to try to applaud these efforts, really kind of fell short. So strategies of what one can do if confronted with these issues is to ask a direct question. So, for example, if someone asks me, where are you from? I could ask back, what do you mean? What are you trying to get at? Can you explain better what you're trying to ask me? Assume the best, and this works well if you know the individual and they may not have realized what they were saying, and say, I know that you didn't really mean that, but it came across this way, and try to explain in a private way what just transpired. In a similar way, to call someone into the office or call someone in and let's get out of the hallway and just talk about what happened. Call someone out, I think, is harder for us, for you guys, and for me, because there's always someone else we're reporting to. I think residents and medical students, graduate students, staff are all in a very vulnerable position because you have to report to someone, and for you to call someone out could be the end of your career or the end of the residency program. If you were to report it and there was an investigation, then your residency program could go under probation. So I think it's very, very difficult to call someone out depending on where you are in your training or in your career. To try to laugh it off and say, I know you thought it was really funny, but it wasn't funny, and this is why I think it wasn't funny. To be honest, to say, what you just said or what you just said to Jill really made me uncomfortable. And, or, if you see something where they're saying, well, the free flap on the floor is X, Y, or Z, and because, just kind of the way that the person is approaching this free flap rather than talking about the patient as an individual, is to try to frame it in such that I wonder if we could provide better care if we did this, rather than just saying, well, just do this and that and without regard to the individual. I think trying to look through the lens of, I know you have everyone's best interest at heart. I know you're a good person. I know you didn't really mean that. Another way of saying that, what you just said could be interpreted as X, Y, or Z. And this is where leadership really, really could be improved because, we can do training for leaders, and I think this is where, since they have the respect of the group, since they have the authority of the group, if they were to speak up and say things like this, would really do a lot to change the culture of the group. So what happens when the patient is biased? I think I described briefly when I first started here at Emory. I had a patient, and we had another, it was just two of us. One was a head and neck surgeon who had been here for eons. Everyone in Georgia knew his cell phone number and would just call him to send patients up. And then there was me. And a patient came in and said, I think you're too young, saying this to me, I think you're too young to be my surgeon. I'm going to go see the other head and neck surgeon. So I said, okay, fine. So she went to see the other head and neck surgeon, and then about 3 or 4 years later, she came back to me and said, well, now Dr. So-and-so is too old, so now I'm coming back to you. And so age is really one of the most commonly reported types of bias from patients against their physician. Ethnicity and national origin can also be an issue. Gender is an issue, as I already gave one example. Race, religion, weight. I've had people ask me if I'm Christian, and if I'm not Christian, then they may not want me to be their surgeon. And so it puts us in luckily, I haven't had too many political questions. I try to step out of that as quickly as possible. Accents, I think, can also be a source of bias, and like that film said, oftentimes, and I think all of us have been guilty of it. If our patient doesn't understand English well, sometimes we just shout louder as if that were to make it more clear. Do you have any pain? Rather than just, do you have any pain? And I don't know why we do that, but that is something that I've seen happen over and over again. Foreign medical grads automatically have this sort of aura about them that somehow they don't know as much as we do. And I think that in no place has, and in no time has this become more clearly wrong than during this past few months with the COVID-19 issues. I think there was a lot of we're not really sure what's going on in China, and they may not know what they're doing, and maybe that's why it's such a big problem. And same thing for the Italian doctors, but actually they, if you look at as more information's come out, as more papers have come out from China, they really did know what they were doing. They really were reporting very much on the front line, and very few people were listening. So again, this sort of persona or impression that medical education outside the U.S. is less good or less valuable than what you would obtain in the U.S. Can be erroneous. And sexual orientation. So about 60% of people have heard an offensive remark about one or multiple aspects of their characteristics from a patient. I've also seen residents and nurses where a patient is saying, well, I wish I were meeting you at somewhere else, like at a bar rather than in this office, and those are all sort of things that can be very annoying and irritating. Male and female physicians experience bias differently, so some of you on this call right now may feel, I have no idea what she's talking about. This whole talk seems to be a total waste of my time. I don't even know how she got on the agenda. But really, it's the life experience of males and females that experience it differently, and that's why some of this resonates more with some of you than with others. But it's a all of us problem. It's not just their problem versus not my problem. Race is also a way in which people hear things differently. African Americans and Asians have the highest rate of hearing negative comments about them. And the emotional impact of this bias can be profound. And like I said, the more you experience these biases, the more it has on the sense of well-being and sense of belonging. And therefore, it can have an impact on how likely and depression and anxiety and things like that. So, and it affects people very, very differently. For most males, it doesn't really have much of an effect. For females, they tend to take things a little more personally. And they're more sometimes more reflective of things that just happen to them. And I just wanted to share another example. This had to do not so much with a biased comment, but just the way that males and females can receive news differently. So recently I was looking at a position in leadership, and I was not allowed that opportunity. I also I was talking with another individual who also was going for the same position, and we were comparing notes after these decisions had come down, and he was a male, and he was just furious with the organization and their selection process and said, it's all them, it's the organization, they don't know what they need, they're short-sighted, it's just the organization's fault, essentially. For me, I was like, oh my God, what did I do wrong? Where are my pitfalls? What are my shortcomings? How come I didn't get selected? It must all be me. And when I had that conversation with him, I was just like, wow, this is really profound about how different our reactions were to the same exact news. And I think that tells there's work for all of us to do in terms of having more reflection perhaps on his part and less reflection on my part, and trying not to take it so personally. So what are some strategies we can do for mistreatment by patients? The acronym is ERACE, which is, I think I took this from a Yale website. E is to expect it, so just be aware. So if you know it's going to rain, have an umbrella. Same thing. If you know you're going to see it today, you know you're going to see it if you're going to be interacting with anyone, with patients or in the OR or on the floor. Recognize it and say, check in with yourself and pay attention to how your patients treat your colleagues. If it doesn't feel right, then please speak up. And you don't have to do it in a very gruff way. Just kind of bring it up and say, hey, I saw that kind of thing. Just saw that. Don't want to see it again. A is for address. Be prepared with a script. Setting boundaries can help. I have patients who sometimes will insist on calling me Amy, and I just say, I prefer to be called Dr. Chen. And then they're like, oh, okay. but sometimes I've been, at one time I did that, and my Press-Ganey report was that I was too pompous because I expected to be called Dr. Chen, and it was just very, very, it was kind of a wild comment that they made about that. Support, check in with your colleagues, particularly for those that are greater at risk, and I've gone through many, many slides to help you identify people in your posse who may be more at risk, and to check in with those individuals. Seek support from your supervisor or your attending. Ease to establish or encourage, and one of these things is to approach your own institution about developing workshops and training modules. Things that I have done are to be one of the first unconscious bias facilitators or trainers at the university and at the School of Medicine level, trying to develop more opportunities to have these discussions. I've talked about these issues at several departmental meetings, not only in my department, but in other departments, pathology, ophthalmology, urology. And so trying to get the word out and having the conversation. Bias in the clinical environment, it's also a part that's very important, particularly at institutions where you might be serving people that are at greater risk for this, so such as the indigent population or patients who are immigrants. It's very important to try to be alert and acknowledge that oftentimes we, as in the majority group, are less likely to touch or make eye contact with the non-white patient. Empathy and perception of pain, this has been discussed in the past. There was a video that went viral a couple years ago of a African-American patient who was in an ED and was sent home by the white ED physician, dismissing his pain and saying that he was trying to get drugs and drug-seeking behavior and all this stuff. In actuality, he had an acute belly and needed to have surgery. So I think that this is something that we need to acknowledge and try to make sure that we are not treating our patients with this erroneous lens. So this can lead to health disparities because those who have social or economic disadvantage are often those in the racial minorities, and it can lead to people discounting their degree of illness or their severity of illness. And this can impact the ability for health equity in that we're trying to achieve the highest level of health for all people. So can we work around our implicit biases? I would say absolutely yes. We do need to be aware, and we need to acknowledge that these things exist. We need to be concerned about the effects of that bias. So just being aware is not enough. You have to also know that it's not okay because it can have detrimental effects, and to try to apply some of these strategies. Corporate America parallels academic medicine in terms of the level of gender diversity or lack of gender diversity. Those who have more gender diversity usually are more profitable and are more valued, have a better earning structure. And you can see here that the CEOs have slowly increased over time. The percentage of women chairs in otolaryngology still are in the single digits. And even though about 35%, I believe, of all the trainee applicants are now women. The business case for diversity sometimes makes the most sense when we're trying to make the case because, everyone likes to earn more money. And this graph demonstrates that if you have more diversity, at least of gender, on the board, you're likely to have a more profit. And also same for return on equity or ROE. Another example of total diversity index and how that looks for how that translates into innovation. And one of the interesting things here is the Federal Reserve Bank, and this was published in the New York Times last year. Central bank is predominantly male, and they really were trying to increase the diversity even at the research assistant level. So the way that the Fed works is that you have all these research assistants kind of at the bottom, and then they percolate up into being chosen to be part of the board. Each part of the nation has its own federal bank, but then there's the central bank. So what it decided to do, and obviously these are, these require, the research assistant level requires skills that are more attributable to male skills, such as math and economics and science. So what they did was they tried to, and many times what they were looking for was a math degree or an econ degree or something in that realm. They removed that and looked more at work experience. And just by removing that criteria of what your major was, it increased the talent pool. And from there, they were able to develop people through the research assistant level so that it could filter up. And they've been much more successful at doing that than just sticking with the dogma that you must have a math or statistics degree or econ degree. And I applaud them for trying to look at the problem and trying to fix it. So I'm just going to skip through this because we're kind of getting late in time. So the Rooney Rule is something that I think some of you may know. I did give one talk where only one person in the audience knew about the Rooney Rule. Rooney is an owner of the Pittsburgh Steelers, and in 2002, the NFL made a mandate that before you could hire a head coach, you had to make sure that you had a person who was of minority racial background in your finalist pool. And with that institution, you can see this increase in number of minority head coaches in the NFL. The past year, there was, again, a lot of discussion about whether this really has helped, because I think last year it's kind of fallen back down a little bit, but you can see this dramatic increase with the institution of the Rooney Rule in 2002. So these efforts can be made to try to help improve diversity. This is something that was put forward by the National Academy of Medicine to try to improve diversity and inclusion. And I'm going to skip through this because I want to get to one of the things here is that it's very important to think about how this can impact our team and how that impacts wellness overall. I think that there are ways in which we can try to improve that relationship, and that's why I raised those issues with the strategies. So I'll pause there, and I think that's basically the beef of my talk, and see if there are any questions or comments that people would like to share. I know that this forum doesn't really lend itself very easily to this type of discussion, but I welcome any comments. I think in the Q&A thing, you can put in as an anonymous, so you don't have to put your name down.